Yay.
Hello and good afternoon. Welcome once again to this community chats hosted by Montefiore Nyack Hospital. We are patient and community education. My name is Sandra Arevalo and I'm very happy here today to be talking about Between Life and Death with Steve Munsem, who is the trauma program manager here in the hospital. He has a lot of things to tell us. And just a reminder for our attendees that we plan for these sessions to be very participative. So if you have any questions at all for Steve or myself, I don't know how much I know about this topic, right, Steve? But feel free to use the Q&A or chat boxes and write down all of your questions because you don't always have the opportunity to be talking one-on-one to an expert who can answer you, especially about like trauma and what to do in life and death situations. So welcome, Steve. I'm very happy to have you here. You've been in community chats before and I know you're amazing. So I'm very excited. But start by telling us a little bit about you, how you became like an expert on trauma and all of that. Tell us a little bit about your background, please.
Well, I've been working in the medical field for a long time. I started when I was 18. I joined the Air Force and was a medic. So did 4 years of that. And then I went into EMS and did many years of that. I just went to nursing school in 2009 and went into the emergency room. That's pretty much all I've known is emergency medicine until this last November. The trauma program manager job opened up and I thought, well, I'm gonna try something a little different after all these years, try something a little, still related to, emergency medicine, but it's a little more focused than, I was working as the educator in the emergency room and it's a difficult environment to try to do education in because things are always crazy and people don't have time. And if they get a minute or two that are down, they just like to relax and get a drink of water or something, not listen to me. So it's a different environment than this, but I still get to do education, throughout the hospital related to trauma. And luckily I get to do community education. I'm looking forward to the pandemic being over so we can do live sessions. We have a lot of good programs, but most of them are on hold still because of COVID. So hopefully down the roads we'll have get to meet everybody live and in person and have some fun.
Great.
So,
and Steve, let me start by asking you a question. So you just said something very interesting to me, and I know this because you come from the emergency department, but
right.
Like don't do like all traumas come to the emergency department? Is that a stupid question? I'm sorry, but since I don't know.
No, all the traumas, all patients that come, well, I shouldn't say that, but 99% of the patients that come to the hospital and get admitted come through the emergency room. There are some, they don't do much for direct admits anymore, but there are some doctors that still have privileges to do that. Even a lot of patients that have minor trauma go to urgent care, which is great, but some of those get sent over here because things are worse than they thought they were when they went in. So, or there's a question, need a CAT scan or something on top of what they're doing at the urgent care. They can do a lot of good things at the urgent care, but sometimes things are a little beyond their scope. And they're really good at recognizing that and sending the person to the emergency room to be checked out. So
yeah, and Steve, I think that you're bringing up a very important topic, especially for our community. Like there is definitely a difference between urgent care and emergency room. And a lot of us just tend to think of emergency room and go to the emergency room when we can actually use an urgent care. So what is that difference and when should we go to either one or the other?
Well, it's kind of hard sometimes. If you cut your finger with a knife and you go to the urgent care, a lot of them can do, minor sutures, depending on how bad the cut is. If it gets down to tendons or anything else, then they're going to send the patient to our emergency room. And a lot of those patients are going to end up being actually sent down to the Montefiore main campus because they need to have specialists to work on, tendons and ligaments if they get cut. So urgent care is it's a good place to start if you're feeling okay. If you're in any kind of a accident or you fall and you hurt yourself at home or anything else and you're feeling dizzy or you're not feeling right, I would go to the emergency room because you're probably going to end up there anyway. But if you just have, if you twisted your ankle, emergency care or, or a wrist, or you have a pain that's not really related to, a real big injury, then I might start at the urgent care because that might be all you need, right? To go to the emergent care, they can do an x-ray and say, nothing's broken, put a splint on or an ACE wrap and send you home, and follow up with orthopedics if it doesn't get better, which is what we would do in the emergency room as well. So, some of those minor type things definitely can go to urgent care for a good starting place anyway, because they can handle a lot of it. So what we're looking at, the trauma program, we look at any patient that's admitted to the hospital with a trauma related diagnosis. So basically any kind of injury that gets admitted to the hospital is part of the trauma program. We have to follow those patients. So I'm going to talk about that a little bit later, but we can talk about it now too. So, and then I follow the patient. I'm learning a lot about the job myself because I just started in November and I had no clue what I was really getting into. But I know how many patients come through the emergency room and what traumas those were, but I didn't really realize it was, following the patient from emergency room through their whole admission until they get discharged. There's a lot of steps that I did not know about, which I'm okay with, but I'm learning a lot.
Yeah. Now let me tell all of our attendees that what you're saying is not true. You really know what you're doing. I know that for a fact. Otherwise, you wouldn't be sitting there. But
I know what I'm doing, but I didn't know what all I was getting into. I didn't know how much it entailed, but.
Well, we all have something to learn no matter where we are, but I know that you're great at what you're doing because I see you
6 months in, after 6 months, I got it figured out pretty good now. So.
Okay, you have a presentation for us. So go ahead and start whenever you're ready.
So for questions, you want to just do the chat for questions or?
Yes, so we're going to be using the chat for questions.
Okay.
So to all
I don't mind interruptions. So.
As Steve is going through his presentation, just start putting all your questions either using the Q&A or chat box, and I'll be reading the questions to Steve, and we're going to do the questions as we move along.
Okay, so, yeah, like I said, I have no problem getting interrupted. I worked in emergency medicine my whole life, so.
You're used to it. Okay.
Yeah, so I'm kind of not very focused anyway here, so. Okay, so Sandra came up with a nice name, Between Life and Death is the name of the presentation. Oh, my mouse turned off. There we go. So a lot of people, question what is trauma. Even when I took this job, my wife, who worked as a ward secretary, didn't know exactly what like I said, I wasn't sure what I did either, but she really didn't know what fell into trauma. And basically, physical trauma is any serious injury to the body. Okay, those are the ones we really look at. We don't keep track of, like I said, the stuff that probably would have went to urgent care anyway, like some of the little lacerations that get sutured up and sent home, or twisted ankles. We look at more serious injuries to the body. And some of those, you can't always tell if it's serious until maybe the next day. On some things we'll talk about, head injuries where the bleeds. Sometimes they will admit a patient just to watch them overnight if they have a small bleed inside around the brain, because if it doesn't get any bigger by the next day and the person's feeling fine, then they'll probably get to go home. So, but you don't want to go home and take a chance on finding out it's getting worse, because things go bad fast. And there's two types of trauma. Most of what we see is the blunt force trauma. So that's when either an object hits the body or the body hits an object. And some of those we get deep cuts, broken bones, and a lot of that is the bruising. So it's generally motor vehicle accidents. And the big one here is falls, which I'll show you that. That's one of the things I want to concentrate on a little bit, is falls. That is the number one injury or mechanism of injury for anybody 65 and older is falls, which I was really surprised when I started this job, how many falls we really see in a year in the hospital. So, and penetrating trauma, we used to see hardly any penetrating trauma. That's when an object pierces the skin, usually creating an open wound. So that could be knife wounds, bullet wounds, maybe just gets stuck with a branch or something that goes into the skin and makes a hole. We've seen a big increase in, I won't say big, we're not like New York City, but we have seen many more knife injuries and gunshot wounds, unfortunately, in the last year and going into this year. So it's picking up everywhere. It's not just a city problem. It's out in Rockland County too. So I already talked a little bit about what my job was. So activated traumas, we have criteria for activating trauma of 2 levels, level 1 trauma, level 2 trauma. Level 1 trauma gets the big response. That's the bad ones. And that gets a trauma surgeon coming in, anesthesia, obviously physicians, a bunch of nurses, and I respond to those during the day just to see if everything's going okay and see if anybody needs any help. And of course, we keep everything in them. It's called a trauma registry, where we keep every admitted trauma patient. We have to enter a lot of data for each patient. Another surprise to me. And that goes to the state and to national, so we can keep good statistics on trauma across the country. They give us nice reports on what's going on, how we match up with the rest of the country. I said before, trauma-related education. So I do education with mostly emergency room and the intensive care unit, because that's where most of the trauma patients get admitted. And then community education. And we are certified by the American College of Surgeons, and they want us to do education based on identified problems. So that's why we keep a lot of the data to see what's really going on in our community. I said there's a little increase in gunshot wounds, but there's no sense in doing a lot of education on gunshot wounds for, one every couple months or something. But and here's what we have for trauma admissions. You can see the big part here, 56% of all admissions in the trauma department are falls. So that's a lot of falls. We had 911 patients last year, so you can see it's a lot of patients. 15% is motor vehicle crashes. This is, I thought this was maybe artificially low because of COVID, and a lot of people weren't driving, especially in the beginning, March, April, May of last year. But looking at this year so far, we're at 16%, so I don't think it's a huge difference. We still have kind of the same amount of, somewhere between 10 to 20% are usually motor vehicle crashes. These are just the ones that are admitted. If we have the patients that weren't admitted, because most of the patients in motor vehicle accidents end up going home. They don't have any real serious injuries, so they get treated and released. Bicycle, Rockland County's got a lot. Everybody's probably seen that. A lot of bicycle groups going around. It's every Sunday we get a bicycle accident because everybody comes up from the city riding their bikes and either gets hit by a car or hits one of these nice potholes that don't feel good in your car. So imagine on a bike, they're really bad. And they come in, a lot of those get admitted because they hit their head or fracture a large bone. Like I said, assaults is up from last year. This used to not even be wasn't even a piece of the pie before, but now we're like 4%. Pedestrian, these are usually bad. This is the people that get hit by a car crossing the street. Those are bad injuries usually. And then motorcycles, 3% are motorcycles, which also most of those end up being kind of bad accidents. So, and this 13% here is, I don't want to make the pie too crazy. There's a lot of little 1 or less percenters like lawnmower accidents. Every year, at least a couple people stick their hand into a snowblower while it's running to unpack the snow and end up here with some bad hand and arm injuries. Same with lawnmowers. Some people don't want to shut it off to pull the grass out. It's just not a good idea. Those are preventable accidents. I mean, some aren't, but those definitely are. It's like power tools. There's a whole lot of things that go into that, sports injuries. So those are in this is in the other department here. So this is what we're going to kind of talk a lot about because like I said, this affects everybody, but the 65 years and older, it's a huge problem, falls. As you can see here by age group, it gets a little crazy here. It goes, we're going along with not very many people, and then we start hitting into the 50s, the 60s, 70s, 80s, and then 85 plus. One thing that's impressed with me is that there are actually that many people that are 85 years and older. We're getting a lot more people living to be, older ages. One of these was 101 years old. So it's impressive to see the age groups getting bigger and bigger. So, but you can see it's percentage-wise, 36% of the patients that are admitted with falls are 85 plus, 26 here and 14 here. So that fits into our, that fits into, you know, let's see, what's that? I had it figured out. 62, yeah. 76% of the patients are 65 years and older that are admitted for falls. So
like 3/4 of the population are already there for falls.
Of the falls patients, yeah, are
65 and older. Yeah.
65 and older. And I'm getting close, so I got to start walking a little more carefully here. So.
And I don't know, are you going to talk about why that is? Like why 65 and older? You know, I'm thinking about my parents who are obviously a little older. So I'm thinking, you know, it's like worse vision, worse balance.
Mm-hmm.
You know, that comes
we're gonna talk about a lot of the falls are in the home. So I do have several slides on, you know, hazards in the home, and some of that is a thing. What, you know, some of the things that are related to why older individuals are falling more than younger individuals. You'd think it'd be more down here because the younger people are doing stupid things all the time, but I guess they bounce better. I don't know. It's just.
Bones are more flexible sometimes.
Yeah. And here's what it says they're not, right? The 65, so 37% of admitted trauma patients had a hip fracture. So that's all age groups. 37% of the trauma patients that were admitted to the hospital had a hip fracture. And 78% of those were patients, you know, 65 years and older. So that's a lot of patients with hip fractures. And one of the bad things, 77% of those patients were living on their own prior to the injury, and then they ended up going to a rehab or a skilled nursing care facility after the fall just for rehabilitation. But so, you know, that's see how severe that is and how difficult it is for recovery, you know, especially as we get older. Things heal slower, takes more time to get up and moving and get back into your normal flow. So like I said, a lot of those patients end up going to rehab or nursing care facilities. And unfortunately, some don't get out of the nursing care facility once they get there because just don't progress as well. Actually, we start looking at the 85 years plus. That's a really big, that's a major major surgery getting hip repair. So takes a lot out of you. Any questions? I see some. I saw some things up there. Okay.
Yeah, Maria is asking, what can we do to prevent falls in adults older than 60? I think you're going to be talking about that a little later, right?
Yeah, I got some things around the home that can be little things that you may have thought of or may not have thought of. So we'll cover that part pretty good here in a few minutes. Yeah, we're going to talk next about, you know, some of the common injuries and what you can do, and then we'll go into things around the house that cause problems. There's not much you can do about outside of the home, really. Mm-hmm. You know, if you're in an environment that you don't have any control over, there's not a lot you can do. You can be more careful, but you can't really change, you know, you can't change parking lots and stores too well. But if the stores did some of the same things that we're going to talk about in the home, they'd be safer too. But
do you know if the majority of these falls happen at home or outside of home?
Most are at home.
Oh, wow.
Especially at 65 years and older, or even the younger people get a lot of. Mm-hmm. You saw where they had less than 1 year old. There were actually, you know, several of those. You wouldn't think they would have them, but the kids rolling off of beds, you know, or on changing tables, and mom turns for a second and they roll off the side, or, you know, or their siblings remove the gate from the steps and the kid tumbles down the stairs, you know, things like that. So you can try to take steps, but there's still things that happen. So that's one thing about hip fractures. Another thing that ends up being one of the more thing with head injuries, they're either really simple or they're critical. I mean, there's not a whole lot in between. Either it's really bad or it's not so bad. There's not a lot. They're just kind of, a couple things. I know I'm probably not going to remember this later, but I'll just talk real quick about the two major bleeds we look at are the epidural hematoma and the subdural hematoma. You can see with epidurals are the worst because it's actually an artery that gets lacerated. This one shows a little skull fracture, so maybe the bone cuts the artery. Sometimes just enough force will cause the artery to tear. As we get older, the brain starts to shrink, and the vessels are still attached to where they were before, so there's more room for the brain to move around. So if you get into an accident and your head gets jarred really bad, it can, pull and tear one of the arteries. And these bleed fast. So these are the ones that are really have poor prognosis, and a lot of these patients, if they have bad epidural hematoma, don't survive without, surgery. So you can, the neurosurgeon can go in and take the blood out, and hopefully the bleed will repair itself. But arteries are tough. The other one, subdural hematoma, this is more in the brain itself, and those are veins that are bleeding, so they're a slower bleed, so they don't always show right away. The main reason I tell you that is because one of the weird things about the epidural hematoma is you might get in a car accident and you think maybe you're not sure if you got knocked out, or you know you're unconscious for a couple minutes or a minute, and you say, well, but I feel fine now. That's one of the big things about the epidural hematoma. Your head got hit hard enough that you get knocked unconscious, and then you wake up and you feel okay, and you say, well, it's no big deal. But as this bleeding continues, within the next, depending on how bad it is, within minutes to hours, this is going to become so large that it's going to push on the brain, and you're going to become unresponsive again and unconscious again. And by then, it's a big enough space that has blood in it that it's going to be really difficult to manage. So really, anytime you're in a car accident and you get knocked out, you should go see somebody, get evaluated. And then the other one is the subdural hematoma. Like I said, it's a slower bleed. The problem with this one I said is a problem because you get knocked out and then you come right back and then you go bad again, but you think you're good in between. The subdural hematoma, you might hit your head, you might fall and strike your head. Might just feel, we've all hit our heads and you kind of go, ow, you don't think too much of it. With the subdural hematoma, it's a slow bleed, so you may not even see signs or symptoms for, days to weeks before blood accumulates enough that it's actually starts pushing on the brain and causes you to become, altered. So, and then you throw one more thing in the blood thinners, and that makes it even worse. So if you're on blood thinners and you get knocked out, definitely want to be evaluated. Like I said, that's something, if you don't want to go to the emergency room, at least go to urgent care and, be evaluated there. They can do a neuro exam and decide if they think you need to, come to the hospital. But if the ambulance shows up and you got knocked out, I probably would go to the hospital and get checked out, because you just don't know. And one other thing with head injuries that people are confused on a lot, and we've seen it quite a bit. It's more with the younger people, but the parents bring the child in and want to have them CAT scan done to see if they had a concussion. Concussions don't show up on x-rays or CAT scans. That's just got to be, you're evaluated, and there's certain criteria you meet to say it was a concussion. There's no way to do a test and see if a person had a concussion. So it's just assumed if you got knocked out and then you're dizzy afterwards, and some other things, that you had a concussion. There's no way to confirm it. So kind of like Alzheimer's, there's no definite test to. Okay, so when should you go to the emergency room? These are the big ones. Okay, if you lose consciousness or become confused after you're injured, you should, like I said, be evaluated. If the injury was at high speed, if you're in a high-speed accident, you really don't know what could have happened. You may not even have any marks on you, but later on, maybe the seat belt going across your chest and abdomen, did some damage internally. You may not know about it for a little while. If you're vomiting or feel nauseated, if you have trouble with your balance, if you can't remember things about the injury, if you didn't get knocked unconscious and you can remember you had an accident and there's just little things you forgot, that's kind of normal, just because of the whole thing. I don't think anybody really remembers the entire accident after they've had one. I've had a couple, and I don't remember the whole thing. I remember the deer jumping out in front of me, and then I remember being in a ditch, but I don't remember did I turn this way or what did I do? I don't remember the whole thing, but you kind of have an idea of what happened, at least. If you can't remember anything about it, you'd say, well, I don't know, last thing I saw, I was driving down, 9W, next thing I know, the ambulance is here, then you probably want to get checked. So seizure is a big one. Get pressure in the brain will cause a seizure. So anytime I would think anybody who has a seizure that doesn't have a history of seizures is definitely going to go to the hospital without having to say that. If you start bleeding, and then hours to days after, if you didn't think you had any real symptoms initially, and you go home and a couple days later you still have a headache that just won't go away, you're taking Tylenol or Motrin, the headache won't go away. If you're not sure, I would probably recommend Tylenol because it doesn't really affect bleeding as much as Aleve or Motrin or aspirin. If you start acting not normal, so unusual, or you got mood swings, trouble concentrating, slurred speech, for any reason, if you have slurred speech, you should be evaluated. That's huge. We're not going to get into strokes today, but slurred speech is a big sign of stroke, which is also a lot of times, either bleeding or a blocked artery in the brain, so the brain's not getting enough oxygen. And that's pretty time sensitive. You need to get in, and there are treatments we can do if you're in like the 3 to 4.5 hour time frame. There are treatments that can be started right away that help quite a bit. Numbness, dizziness, have difficulty falling asleep or waking up, so just changes in sleep pattern, changes in your eyesight, or you have trouble moving your eyes. If you have pressure in your brain and it's pushing on your eyes, sometimes the muscles can't work to even look side to side. So I imagine most people would be concerned enough to go get checked if that was happening to them. But and if you have discharge from your nose or ears outside of normal, if you have allergies and you got a little bit of runny nose that you probably get every time like that, if you want to get checked, you could, but be more worried if you don't have any history of, runny nose or anything, and all of a sudden you start having a runny nose. There's a lot of times what happens in head injuries is you get a small fracture in the skull, and that can leak into the ears or into the nose. So you're actually having cerebral spinal fluid leaking out of the ears or nose, and that's not a good thing for a couple of reasons. One, you need that in there to lubricate and protect the brain. The other one is that means you have an opening in your body to the brain, so you got a pretty good chance of getting an infection, maybe getting meningitis, and we know that's not good. So it's best to get checked. Again, if that's all you had, no other symptoms but discharge from the fluid or nose or ears, that would be something you probably could go, to urgent care if you don't want to go to the emergency room. They could look up your nose, look in your ears, and see if you have, an infection or anything else going on, and do an X-ray to see if your skull's fractured. So, okay. Any questions about head injuries that popped up, or?
No, we're okay.
Okay. This is one I didn't even think about putting in until I thought about my house, and this is the newest guidelines, and I've been telling my wife to do the wrong thing for a while. So last thing I had ever heard was you tilt your head back and you pinch your nose. Now they don't tilt your head back. So I wanted to throw that in there just because a lot of people, more so in the winter, I think, when the house is really dry, you end up getting nosebleeds. So things that do pinch the soft part of the front of your nose. So pinch your nose, tilt your head forward and breathe through your mouth, and see a doctor if the nosebleed doesn't stop in 10 minutes. Some places I've seen say 20 minutes. So, you could go a little longer than 10 minutes and see if it stops, because sometimes it does take a little bit. So what they don't do is do not pack the nose with tissues or other household items, and do not tilt your head back or lie flat. Problem with that is if you lie flat, the blood is going to go down into your mouth and into your stomach, and the body doesn't like blood being where it's not supposed to be. So if you get blood, if the blood goes down into your stomach, you're going to end up getting nauseated and vomit, and that's not going to help your nosebleed at all. So tilting forward is the way to go. And once you pinch, keep the pinch. Don't stop, because what you're doing is letting the blood have time to clot in your nose. So you don't want to keep stopping and checking, seeing if it's bleeding or not. Just go for the 10 minutes to 20 minutes. Just keep. I know it's not always the most comfortable thing, but you need to let the blood coagulate in your nose, so it'll stop the bleeding. Definitely, if you're having frequent nosebleeds, you probably want to see your doctor, and they can take a look and see in the nose if you have maybe a vein or an artery that's causing a problem. The other thing is, if you're on blood thinners, definitely want to be a little more careful with nosebleeds, because chances are they won't stop and it might be more severe. So be careful with that. It's pretty simple stuff, but things we forget, especially especially if you have a bad nosebleed, it can be scary. So you don't want to, just remember that. Just pinch your nose, lean forward, and then after that, you can figure out what to do. They do say not to pack the nose with tissues or other household items, but if you're a long ways from the hospital and the bleeding is just not stopping, one of the things we do in the emergency room, one of the first things they do is, well, now we have a little fancier thing, but one thing we have is they're called nasal tampons. It's just a long, skinny, basically just like a regular tampon that expands once it's in the nose and stops the bleeding and puts some pressure on whatever blood vessel is causing the problem. So I guess I'm being recorded, so I guess everybody know I said it, but if you are a long ways from the hospital and you need to go to the hospital and the bleeding just won't stop, a regular tampon, if it's small enough to get in your nose, would do the same thing, at least to stop the bleeding from, being severe the entire time. Okay. Said I didn't say that, but I would do it. Okay. So with a nosebleed, when should you go to the hospital? Okay. If the nosebleed is from an accident, okay, if you just had a nosebleed from a car accident, you probably should get checked. There's more blood than you expect for a nosebleed. If everybody's had a nosebleed, it bleeds a fair amount, but we see patients that have an artery that gets ruptured in the nose and it bleeds nonstop and huge amount of blood. I mean, you're filling up a bucket of blood, and that's not good. It affects your ability to breathe. Bleeding lasts for longer than 20 minutes, even with pressure. And if you are losing a lot of blood, I think you need emergency care. One of the things with blood loss is your blood pressure is going to start going down. You can get dizzy, so you don't want to drive yourself to the hospital. The last thing you need to have is a motor vehicle accident on the way to the hospital because you got dizzy and ran into a car on top of what you already had. So call 911 or if you have a friend or family there, they can take you, but otherwise call 911. And if you're alone, just to have somebody driving that is going to get you there. So, okay, regular bleeding. This is always a fun one. And like I said, this can be a life-saving thing, right? If you have a cut to your arm or your leg and it just won't stop. The other thing we see sometimes is, varicose veins rupture. Somebody hits a table going by and you wouldn't think it would be bad, but those start bleeding and they just won't stop. So 99% of the time, just they show with a glove on. If it's you don't have to put a glove on before you put pressure on yourself. If you're going to be a good Samaritan and help somebody, it probably wouldn't be a bad idea. Unless you don't have any, then it's a decision you have to make yourself, right? Unfortunately, I don't think, right, if I see something, I just go over and do it, and then afterwards go, I should have probably had a glove on. But put direct pressure with the dressing. See, they have like a 4x4. Actually, it looks like a bigger gauze dressing, but you can use, a washcloth or a small towel. If you don't have that, you can use a clean sock. If you don't have a clean sock, a dirty sock, anything that's some kind of fabric that you can put over the cut and put pressure straight on it. So this person puts dressing on and then squeezes as tight as they can. And you just hold on to that. And if the dressing gets soaked, the mistakes a lot of people make is the dressing gets soaked, you see the blood's coming through, they take that one off and put another one on. The problem with that is if it's starting to clot underneath the dressing, you pull it off, you pull the clot off, and then it starts all over again. So if it starts to soak through, just put another cloth dressing over the top of that and apply pressure again. So, and continue doing that until it stops or you get to the hospital. So that's probably as far as you'll ever go with bleeding control, but I just put this in just in case, especially somebody with blood thinners might be harder to get them to stop bleeding, just putting direct pressure. So there are pressure points in the body. You can ignore the ones in the head. I wouldn't even mess with those, especially not the carotid artery. I wouldn't push on people's carotid arteries for a bleed on the scalp or something. But in the arm, on the inside of the, can you see my pointer? You can see the pointer? Okay.
Yes.
Yeah, just kind of on the inside of the arm, they're going like they're showing it where they're really putting pressure right on the brachial artery with just their fingertips. You're better off putting the palm of your hand just on the inside of the arm and pushing, and you'll probably get it that way. It's hard to find hard to find arteries inside a person if you don't know exactly where you're looking. But if you put your whole palm, over this area here and pushed, you probably would do enough to slow the bleed down. On the leg, it's on the inside of the leg, just inside the thigh. There's the femoral artery. Again, I would just put the palm of your hand on the inside of the thigh of the leg that's bleeding and just push until you see if the bleeding slows down. And then if it's something bleeding in the hands or fingers, there's two arteries, a radial and ulnar artery in the wrist. Again, just put pressure on the wrist and see if that'll slow it down. You probably need somebody to help you with some of these because you still want to keep the direct pressure on while you're doing this. So it's kind of hard to have two of your hands working at the same time in a bigger area. So just something to know in case, like I said, if you're out fishing or something, or you're out hiking and you get a bad cut and it doesn't stop.
Steve, do you know what about how long you need to keep the pressure, or you just need to keep it indefinite until the bleeding stops?
Until the bleeding stops. The direct pressure for sure until the bleeding stops. The pressure points, again, you can hold it for a few minutes and then let up and see if the bleeding starts, soaking back through the dressing or whatever. And if it does, then I would just keep it until help gets there, or you get to the hospital. Not gonna do this. Honestly, I think I've done this twice in my life, and I've worked a lot of emergency medicine. So pressure points aren't something that you need to use. A lot of times the direct pressure does the trick. We don't do the direct pressure points really in the hospital anyway, because if it gets too bad, we get one of these nice little tourniquets out. These are the commercial tourniquets that EMS, actually military started using them first, then EMS started carrying them, and now the hospitals have started, carrying them as well, because they're designed to do that. In the past we used to use other things for tourniquets that weren't always the best. Really, one of the best tourniquets you can have is if you have a manual blood pressure cuff. That is one of the best, because you can really control the pressure. The big thing with tourniquets is the width. You don't want to have, I know the war movies, they show people pulling their shoelaces out and wrapping them around their arm or leg and tying them off real tight. The problem with anything that's really narrow is it ends up cutting into the skin while you're twisting. So you want something that's, like, this is probably only like 1.5 inches, 2 inches wide, but at least it's not super thin. And these are commercially available. Like I said, if you're somebody who's on, it sounds stupid, I know, but if you're somebody who's on blood thinners, they're not that expensive on, like, Amazon. Not that I'm advertising Amazon, but that's the only place I shop anymore, I think. But, and I bought a couple of them just because I'm on blood thinners and I just don't, you never know. But if you're going to be out, like I said, doing something out in the woods, or, going camping or fishing or whatever, and you're going to be away from any help, they're only like $10 you can throw in a bag, and they're really easy to use, and you never know, right? It might, you can only use them on, tourniquets are only good for arms and legs. You can't, obviously you don't want to put something on your neck and twist it tight to stop a bleeding in your forehead, because that would not go so well. That's a bad thing. So, and then this is the improvised tourniquet. You see where they show, they're using their belt, but they put a dressing underneath it so it doesn't cut in. And you want to put it just a couple inches above the wound. Then you put a cloth around and you put a stick through and you start twisting until the bleeding stops or slows down. You don't even have to stop it all the way, just till it slows down. It's probably the best, because you don't want it so tight that it's cutting off all blood flow to that extremity, because then you're going to start having, fingers and toes dying off if they don't get any oxygen for a long time. So it's mostly just to slow things down. And again, this is like a last resort. I wouldn't recommend people putting tourniquets on unless, like I said, you're out of ways where you're not getting any help and you just can't slow it down and it's bleeding a lot. So, but it is an option. And then besides the direct pressure, you want to elevate the extremity so that the wound is higher than the heart, and then continue the pressure until bleeding stops. You can use anything for elevation. They got a nice little stool here. It looks a little high, probably, for it's doing the trick. Looks a little uncomfortable, but just even a couple pillows is enough to get it above the heart. If you're laying flat, you don't have to get too high to be above the level of your heart. So I guess higher is better, but you don't want to cause any other injuries by doing that. So don't use your really good, anything that you can't live without, don't use it, because if you get blood on it, you're probably not gonna be able to get it out. But it's an emergency, I guess, don't grab the Vuitton bag, I don't think. Okay. Any questions on bleeding? The one thing I forgot to put in here just really quickly is burns, mainly because we don't keep track of burns in the trauma registry, so I kind of spaced that one out. But burns, if you get a bad burn, if you have a burn to an entire arm or entire leg or all down the front of your body, you definitely want to get checked out. Again, you could go to urgent care or to the emergency room. The one thing that people do make a mistake, though, is what to put on a burn. We see all kinds of things come in, from anything from mayonnaise to butter, people, throwing Crisco on or something like that. The only real problem with that, you're not really probably doing a lot of damage, but the problem is it's hard to get off, so it's pretty uncomfortable to get that all scrubbed out. The new thing for burns and what we do here for, semi-minor burns is just like a antibiotic ointment, like, a Neosporin or bacitracin. Just put that on, that seals the problem with burns is they hurt as long as the air is getting to them. So if you put bacitracin or Neosporin on, it'll cover the tissue and not let the air in, and it's an antibiotic ointment, so it'll keep things, from getting infected. If you're going to manage it at home, the other thing people do is put Band-Aids on. I got nothing against the Band-Aid company, but in the last few years in the hospitals, we don't use as many Band-Aids, especially the plastic ones, because it doesn't allow anything to breathe. So they've gone more to, just putting on gauze and taping it on loosely on burns rather than, putting a big old Band-Aid on. So those are the big ones. The ones you definitely want to be evaluated, though, if you get a burn on the palm of your hand, the blisters, or on your feet or groin, any of those areas, you probably need to go to a burn center, which would be in Westchester, or at least a burn clinic, because a lot of times you're gonna need to go through physical therapy with those, because the burn starts to contract, then you can't use your hand properly. So those are the ones you got to worry about. Okay, now as promised, preventing falls in the home. Right? Okay, so a lot of this stuff is common sense, right? If you have it, throw rugs are one of the killers here. See this poor little lady just walking and catches the edge of the rug and falls. The carpet too, if you have ripples in the carpet, it might just be enough to catch your toe and trip you up. So if you have loose carpeting, you want to get that fixed. And if you are going to use throw rugs, because some people really like throw rugs, they recommend using double stick tape to stick them down, and that's at least a little bit safer than having the rug just loose. The two problems with throw rugs, obviously, one is, like I said, catching an edge and tripping. The other one is the rug slipping out from underneath you and you fall and do something terrible. Next thing is move furniture and electrical cords, keep them out of the walking paths. We see a lot of houses where the chairs, are right in the doorway into another room, or into, out of the living room into the hallway, and you can catch your foot on one of the legs, or just catch the edge of the chair and fall. And then electrical cords. This looks like it might be a heating pad cord. That's probably you want to know where your cords are. Just keep them away from your feet so you don't get tripped up. So a lot of this is common sense. Wipe up spills right away. That's one of the ones that, like I said, stores could make things safer for everybody if we wipe them up right away. Even in the hospital, we have falls from water that gets spilled on the floor and nobody told anybody, and somebody slips on it. So luckily, usually it's just employees. But if you use a walker or cane, put rubber tips on the legs. Okay? I know I've seen a lot of creative uses of tennis balls and stuff on walkers, but I know everybody wants to make them slide easier. But the idea of the rubber is to keep, if the walker starts getting away from you, the rubber stopper should slow you down, where the tennis ball is just gonna make you go faster, or those slides. So that's one. Lighting's a big thing. Keep your house well lit. Night lights in the hallways and bathrooms. They do make the motion sensitive lights if you don't want to, have a light on all the time. Just having a motion activated light in the hallway or in the bathroom, just to make things a little easier to get around. You never know. If you're home alone, maybe you won't leave things everywhere, but if you're with anybody else, you never know what might end up on the floor or get moved. This looks like my house here. Yep. Can't train my wife to not get up on the most items. The things you use most frequently, they recommend moving to a lower cabinet so you don't have to do things like getting up on chairs or climbing up on the countertop to get something out of the top cabinet. So the bowls you use, the pots, pans you use all the time, put them in the lower cabinets, and stuff that you don't use as often, put them in the top. Makes sense, but things you don't really think of sometimes. It's just, that's where it's always been, and you just leave it there, right? That's, you know where to find it then. Keep a cordless or a cell phone and a flashlight at your bedside. Okay. If you get up at night, it's nice to have a flashlight, especially if you don't have the night lights in the hallway or the bathroom. Wear low-heeled shoes that fit well with non-skid heels, so no 6-inch heels. Just got to use something. Sandra, what? You're young yet. You can still do it, Sandra.
Yeah, you're just saying that to be nice to me because you see me on my heels all the time.
All the time. Yep. And they say it, and not just shoes, of course. It's, you know, slippers. Make sure your slippers are non-slip too if you're wearing slippers around the house. So some of those are really, I've seen some that are just really slippery on the bottom. So okay, don't wear socks without shoes on wood tile floors. I'm guilty of that around the house all the time. I don't wear shoes in the house, but it's not a good plan. And especially if you have wood floors in the kitchen and you cook with something with a little bit of grease and somebody gets on the floor and you don't notice it, or you do notice it and you wipe it up, but you don't realize that you left a little more grease behind, and then zip, you're on the floor. Loose toilet seats. If the toilet seat's loose, fix it or have somebody fix it if you need help doing that. You'd be surprised how many people come in because they fell off of a toilet that had a loose seat. I was surprised. It does happen though, you know, if they're really loose. Some people let them really get really wobbly. Not good. This is one thing that's kind of really helpful in showers, especially installing grab bars and non-skid mats in the shower tub. We get a lot of injuries getting into and out of the tub. You know, you step out with one foot and the other foot slips and boom, down you go. So, and if you're like me, you probably don't want to pay the money to necessarily have all these things installed. They do make, you know, these little clip-on ones. They just stick over the edge of the tub and clamp down, so you can just, you know, use that as a bar to get in and out of the tub. Just check once in a while that it's staying firmly connected, but it doesn't, you know, something you don't have to do any drilling into your tile or do any damage to your tub. It's just a little, sits down on the, like I said, on the edge of the tub, you tighten it up and it's there for you. So kind of nice. The other thing is shower chairs. I know people don't want to admit they need shower chairs, but you know, sometimes, especially if you get out of the hospital and you've got, you know, recovering from an injury or something, or you're feeling a little sick, it's kind of nice because if you get dizzy in the shower, there's really nowhere to go except down, and that's, you know, not good for you. And then the other thing is these shower heads that you can use handheld. So while you're sitting in the chair, you can spray off your whole self. It's kind of nice. Make sure your eyewear is current. Like me, you only go every few years to get your eyes checked, and you know, you might have had a change in vision, that things are getting a little blurry, and that might affect your balance. I notice it now because I wear contacts most of the time, but I do have glasses at home. But if I put the glasses on, it feels like it takes me 10, 15 minutes to get used to them. It's kind of everything's a little bit off. So make sure they're right. This guy's got some good ones here, right? About 1.5 inches thick. Another one people don't think about is prescriptions. You know your prescriptions and know what interactions there are with prescriptions. I mean, doctors should be good at not giving you anything that's going to make you too dizzy, but things that you don't even think about. A lot of things will put, you know, may cause dizziness, drowsiness, or lightheadedness. But things you don't think about if you're released from the hospital and they put you on like a diuretic like Lasix, people don't think that that's going to not necessarily may make you dizzy because you're urinating a lot more, but the other thing is it's making you get up more than you're used to, and sometimes getting up in a hurry because, you know, you laid down and the Lasix kicked in and your bladder gets really full before you wake up and say, oh, I got to get to the bathroom, and you're moving too fast and you slip and fall. So medications are good. I love this. I found it on there. This is showing that doctors don't always look. This is the cat got antibiotics prescribed, and they put the sticker on that says may cause drowsiness. Don't use alcohol, and don't operate a car. So that was a prescription for a cat. And they're wondering, my cat never drinks and my cat never drives, but you know, so the pharmacy and the doctors try hard, but sometimes things get missed and messed up. So Okay. How are we doing? So this video doesn't work. It's kind of goofy anyway, but just showed how to get up. Main thing they say is, you know, don't get up real fast after you fall. If you do have a fall, you know, kind of sit for a minute, make sure you're not dizzy or hurt anything, and then try to find like a chair or a stool or something to crawl over to and use that for leverage getting up. So, yeah, questions, my question picture.
Yeah, well, let's wait to see if anyone
I
has
told you I talked too much, Sandra.
Huh?
I told you I talked too much when I did the test one. It was only a half hour, but.
No, look at this. No, it was perfect. So thank you very much, Steve. And I agree, you know, there are so many things that we can do at home and we just don't really pay attention. I'm guilty of that, you know, like
Yeah, I know.
even when we're cooking or we're gardening, there are so many things that we can do to prevent an accident. And, you know,
That's one of the big things. Yeah, paying attention. You know, it's my daughter did the other day. She was cooking and didn't even, I don't know what she was even thinking, but she just was baking in the oven with a frying pan. 'Cause she, you know, browned it first, then stuck it in the oven, and she just grabbed the frying pan to pull it out of the oven and got a burn in it. You know, like why do you? You just don't think. You know, you're in a hurry. You go grab something, don't even think that something that's been in a 400-degree oven is going to be hot. But yeah.
Yeah, it's just sometimes it's what you said, you know, we don't think, but I think that your presentation has helped us. I know it has helped me to think about a couple of things that you mentioned that I actually do, like, you know, putting the things that you use in the kitchen closer to you so that you don't have to be climbing the stairs, especially when you are my height, right? Like I'm so short. So, thank you for all your tips, Steve. We don't pretend to come and see you in the emergency room. We don't want to have a trauma or
no, we don't want that.
Related, so
I like having a job, but I don't want to see trauma. So
yeah, no.
Trauma goes completely away. I'll be happy and I'll find something else.
Yeah, just by looking at that brain picture of yours, I was like, oh, no.
Yeah.
No.
Yeah.
So we don't have any other questions. So I think that we're going to be saying goodbye to you.
I just want to say one more thing real quick.
Of course.
I mean, you can, if you have questions, you can always, you know, call me too, because that's, you know, that's my job here. If I answer questions.
Excellent. So everybody has my email. So if they want to communicate with Steve, you can email me and then I'll forward your emails to Steve. That'll be nice.
Sure. And then the other thing is I didn't know how I could share a checklist, but the CDC, if you Google for CDC Safe House Checklist, they have a pretty good checklist for things to look at in the house too. And a lot of them we talked about, but some that we didn't. So they have a pretty good checklist that you can, you know, either do yourself or have somebody come over and do it with you, and you can kind of have a little day of checking everything out in the house and checking off the checks on the check mark. So
that sounds
CDC,
really
they're
good.
pretty good. They're a pretty good resource. So that's, you know.
Yeah, that sounds
Thank you for letting me do this today. It was a lot of
course.
fun.
No, and we're gonna be doing many more, Steve. Don't worry about it.
I miss teaching. So.
Yeah, oh my God, I can't imagine. Once you're an educator, I know it's in your blood, so you have to keep doing it. Well, it's 12:58, so we're close to the hour. So thank you to all of our attendees. I hope this has been helpful for you all. And thank you, Steve. Thank you very much for making out the time to create your presentation and be with us today. And I know it's a lot of work that we put on your shoulders. So thank you so much. Thank you, everyone. And I will see you next week.
Okay, thank you.
Take care.